Welcome. So, if you've ever felt totally overwhelmed by the sheer volume of neurology medications you need to know for your exams, you are in exactly the right place. Today, we're going to demystify these complex drugs with a visual walkthrough of their pathophysiology. Our goal? It's simple: to help you see the why behind the what, so you can confidently connect all the dots on exam day.
It's a lot, I get it. Myasthenia gravis, Parkinson's, seizures. Each one has its own set of meds, side effects, and nursing must-dos. But here's the secret. It really all comes down to a few core principles. This explainer is designed to give you a clear, structured path to really understanding it all, connecting the disease process directly to how the medication actually works. By the end of this, you'll see how it all fits together like a puzzle. So let's get started.
Here's our game plan. First, we'll dive into neurotransmitter imbalances. Then, we'll move on to the brain's electrical activity. After that, we'll tackle pain and pressure. And finally, we'll wrap it all up with a rapid-fire review of the critical nursing checklists that you'll use across the board. Okay, our first stop is the fascinating world of neurotransmitters. We're going to look at two huge conditions, myasthenia gravis and Parkinson's disease, where the main problem is an imbalance between these crucial chemical messengers in the nervous system. So let's kick things off with myasthenia gravis. To really get this, I want you to picture the neuromuscular junction. It's that critical meeting point where a nerve has to tell a muscle what to do. The message itself is carried by a neurotransmitter called acetylcholine. Well, in myasthenia gravis, that message gets lost. Why? Because the acetylcholine is being broken down way too fast, and that leads to some serious muscle weakness. So how do we fix it? Well, this is what's so cool about it. The solution is super logical. If you have an enzyme that's breaking down our messenger too quickly, what do? You block the enzyme. And that is exactly what anticholinesterase meds do. They get in there, they inhibit that enzyme, which allows more acetylcholine to just hang around in that junction. That means more messages get through, and boom, muscle strength improves. It's a really beautiful and direct mechanism of action.
But, and this is a huge point for nursing, balance is everything. Too little medication, an underdose, and your patient goes into a myasthenic crisis. All the disease symptoms come roaring back with severe weakness. But too much medication, an overdose, and they go into a cholinergic crisis. Now the system is flooded with acetylcholine, causing twitching, low blood pressure, and way too many secretions. The key to telling them apart is a drug called edrophonium. If it helps, it was a myasthenic crisis. If it makes things worse, you know you're dealing with the cholinergic crisis.
Now let's take that same idea of neurotransmitter balance and apply it to Parkinson's disease. Here, the imbalance is between two different neurotransmitters. There's not enough dopamine, which means there's relatively too much acetylcholine. So the treatment strategy is just brilliantly simple. We have two choices. We can either boost the dopamine levels with dopaminergic drugs, or we can block the effects of all that extra acetylcholine with anticholinergic drugs. Two totally different paths to get to the exact same goal, restoring that balance.
Now, when we use dopaminergics like carbidopa-levodopa, there are some major things to watch out for. Since we're messing with brain chemistry, we can see these involuntary movements called dyskinesia. The met can also cause orthostatic hypotension, so telling patients to change position slowly is a must. And here's a huge exam tip for you. A high-protein diet can actually interfere with how the drug gets absorbed. Just picture it like this. The protein and the medication are competing for the same bus ride into the bloodstream, and if protein wins, less of the drug gets to the brain where it's needed. All right, let's switch gears a bit. We're moving from the chemical messengers to the brain's electrical grid. You can think of a seizure as basically an electrical storm in the brain, just a sudden, totally uncontrolled burst of firing neurons. Our goal with these meds is to calm that storm.
The main goal of any anti-seizure medication is to stabilize the nerve cell membranes. Think of it like putting insulators on some faulty wiring. These drugs calm down those abnormal electrical sparks, and, most importantly, they stop them from spreading to the neighboring neurons. That's what prevents a small, localized flicker from turning into a full-blown seizure.
Now this slide right here, this is exam gold. For these drugs to work safely and effectively, their concentration in the blood has to be just right in what we call the therapeutic range. If it's too low, the patient can have a seizure. Too high, and they're going to have toxic side effects. As a nurse, monitoring these serum levels is a top priority, especially for a classic drug like phenytoin, which has a pretty narrow therapeutic window of 10 to 20 micrograms per milliliter.
Speaking of phenytoin, let's zoom in because these are the facts that show up on exams over and over again. A classic side effect you need to know is gingival hyperplasia. That's an overgrowth of the gums. Giving it IV, it has to be a slow push and you can only dilute it with normal saline. Why? Because dextrose will literally cause it to clump up into little crystals. And for patient teaching, it is vital they know it can make their birth control less effective and it's teratogenic, which means it can cause birth defects.
Okay, now we're shifting our focus again. We're moving from controlling signals inside the brain to managing two of its biggest challenges, pain and pressure. And we're not talking about a little headache here. We're talking about severe pain, a huge stressor, and increased intracranial pressure, which is a life-threatening emergency. For that severe pain, we often turn to opioids. They work incredibly well because they act right on the central nervous system to block pain signals. But here's the catch. The part of the brainstem they act on is also where our breathing is controlled. So the crucial takeaway is this. Every single time you give an opioid to relieve pain, you are also risking respiratory depression. It's a classic case of high power, high risk. And for that high risk, we have a direct answer, naloxone. This is the opioid antagonist, the ultimate reversal agent. It works by literally kicking the opioid molecules off their receptors in the brain, which immediately reverses their effects. It is the essential safety net we need when using these powerful medications. This slide perfectly lays out the nurse's role. Your number one job is assessing the respiratory rate. If it drops below 12, you hold that dose and you call the provider. Beyond that, you're on the lookout for low blood pressure, constipation, and urinary retention, all really common side effects. And of course, you always have naloxone ready to go, just in case. All right, let's tackle that pressure problem. When the brain swells, intracranial pressure rises, and that is an emergency. This is where mannitol, an osmotic diuretic, comes in to save the day. I want you to visualize this. You give mannitol IV, and it makes the blood super concentrated, almost like salt water. As this salty blood circulates through the brain, it acts like a magnet for water, pulling all that excess fluid out of the swollen brain tissue and sending it to the kidneys to be flushed right out of the body. Now, when you're giving mannitol, you are watching that patient's neurostatus like a hawk, looking for any sign of improvement. But because you're causing these massive fluid shifts, you also have to watch for big complications, like fluid backing up into the lungs, causing pulmonary edema. And here it is, the single most important, can't-miss nursing check for mannitol. You must inspect the vial for crystals. If it has crystallized in the vial, you cannot give it, period. Okay, deep breath. We have covered a lot of ground. So now let's boil all this down into a few critical checklists. These are the core principles that apply to almost all of these medications. These are your big takeaways. So the first universal theme you're going to see is CNS depression. So many of these drugs cause drowsiness and dizziness. And what does that mean for us? Patient safety is number one. You have to be assessing their risk for injury and putting fall precautions in place for anyone on these meds. Second, you've got to be a detective. This means you are constantly monitoring vital signs, like that respiratory rate with opioids or the blood pressure with Parkinson's meds, and you're keeping a super close eye on lab values. Like we saw with the anti-seizure meds, checking those therapeutic drug levels is absolutely essential for preventing toxicity and making sure the drug is actually working. And third, your most powerful tool is education. Your patients have to understand these three rules. 1, never, ever stop these medications abruptly. That can trigger withdrawal or a huge return of their symptoms. 2, avoid alcohol because it can dangerously magnify the sedative effects. And 3, for conditions like epilepsy, really encourage them to wear a medical alert bracelet. So as we wrap up, I just want to leave you with this thought. Memorizing long lists of side effects is one thing, but truly understanding the pathophysiology, actually visualizing why a certain drug helps in myasthenia gravis or how mannitol pulls fluid from the brain, that's what really transforms you from just a student into a truly safe and effective nurse. And that brings us to our final question for you to think about. Now that you have a much clearer picture of how these meds work, which one do you think poses the biggest challenge for patients when it comes to actually taking it as prescribed? Is it the one with annoying side effects like the gum swelling, or maybe the one that requires a strict diet? Or is it something else entirely? Give it some thought. Thanks so much for watching.